of SVIN, and also I'm a core executive committee member at the Mission Thrombectomy, which is a global committee to increase the access for mechanical thrombectomy for stroke across the globe. I personally have no conflict. I only have interest. And if I have a large stroke core, please do thrombectomy for me. This is just a disclosure. So as we know, I'm just going to present some data from the US.
Before you start, I think your presentation is not showing.
It's not showing. What about now? Let me just, dismiss, cannot share. I don't know why. Let's see. Share window. Do you see me now? Do you see my picture?
See your video, but no. Okay, yes. No. Yeah. Let me.
But I don't think. Do you see this now or no?
Yes. Yes. We see the screen sharing. Yes.
And do you see the presentation now?
Switch over to it.
I am switching. Let me just. Sorry for the. I thought that we tried it. Let me see. Present something else. Window. Cannot share. Dismiss. Stop sharing. Let's do. Share the screen. Share the screen. Let's see. What about now?
Yes. Share screen. Yes. Now it's showing. I'll pin it for you.
Okay. All right. You see now the next slide?
Yes.
Okay. So just a few numbers. I hate to start my talk with numbers. I meant to keep this talk timetable and just going through how the stroke care evolved over time. So you can see how we started from doing nothing to being the most effective treatment so far. So at the US level, every 40 seconds, if you just watch your watch and you just fast forward 40 seconds, someone in the US will have a stroke, and every 4 minutes, someone will die from a stroke in the US. It is the number 5 cause of death, but it's number 1 cause of disability in the US. And just to give it a perspective, so if you're walking the street in any city in the US and you see someone in a wheelchair and you want to, or using a walker, and you want to see, and you want to guess what's the most likely cause of this patient having a walker as an assistant, it's a stroke. So this is the impact of this in a perspective. So before we go into the stroke, so stroke is not a one-time disease, and this is a very important information to share with your colleague as a physician, and also especially primary physician, but also with the patient. So it's not like a one-time shop. So it's not like an appendix you remove, then that's it. You don't need to see the physician. It's an ongoing disease, and you have to prevent the disease from coming back to you. The recurrence is really striking. So out of the 800,000 American experienced stroke, about 200,000 of those will be a recurrent stroke. And one in 4 of the 8,000 will have another stroke within a year. Those are a scheme of the classification of a stroke. It's either ischemic or hemorrhagic. Ischemic is more common than hemorrhagic. It's more than 85%, and it's the same statistics across the globe. So if you look at any data representing the global stroke incidence, it's the same thing. As I always say, hemorrhagic stroke carries more mortality and morbidity at the beginning, but the long-term outcome from hemorrhagic stroke is usually better than the ischemic stroke. This is just a scheme. So how do we recognize stroke? I know most of you are in the medical field. I'm not here to give you a lecture about neuroanatomy and localization, but I want to give you tips how to educate non-neurologists or people who are not really into the field, or even general public. So stroke will give you one side of the body weakness. I know there's a lot of diseases that can make the same symptomatology, but just to make it widespread, it's one side of the body weak, unilateral weakness, numbness, visual disturbances, vertigo, and you name it. And if you go to a scientific names or description, aphasia, neglect, confusion, behavioral abnormality, and so forth. And since we are in the field of emoji and social media, I like this emoji. So if you're really not able to text anyone that I have a stroke, or tell anyone that someone is having a stroke, just text this emoji. This is the most close to stroke symptoms. But mnemonic for general public, I know there is some mnemonic in Arabic language. I forgot it, but I did see some videos on LinkedIn from Saudi Arabia and Qatar looking at mnemonic, but this is the mnemonic in English: be fast. It used to be only fast, but they added the B and E to include the posterior circulation stroke, that it's quite fairly missed because of its difficult localization. B for balance, any acute balance issues. E for eye problem, either vision loss, blurred vision, double vision. F for facial droop, arm for arm or leg weakness. S for speech, and T for telephone. Just call an ambulance. Do not drive yourself. Do not ask anyone to come and drive you. Do not call a taxi. Just call an ambulance and come as fast as you can. Mini stroke is a very common name that is popular here in the US, which is, it might also be common in the Middle East area, which is like a jalta khafifa, which is like a mini stroke. Mini stroke or TIA, it's not the same. TIA is not a stroke and mini stroke is not a TIA. As we know, TIA is an area that has low perfusion, then the body or something happened, then the perfusion was restored and no scarring of the brain happened. So it does not mean stroke. Stroke means when you have a brain damage. TIA, there's no brain damage. TIA is a warning sign of a stroke. And unfortunately, most of the patients with TIA who comes to the emergency, they get dismissed with no follow-up. Even I did a study in my residency, just looking at our community in my residency program, how many of those patients come back to clinic for follow-up. It is the lowest amongst all stroke patients. The TIA patients, they do not come back for follow-up. And because I think they just see that they recovered, they attribute their symptoms to sleeping on their hand, not sleeping well, I'm tired, and they just do not come. And believe it or not, in few days, they come back with a stroke. Actually, the stroke risk after a TIA is up to 50% within 2 days of the TIA. Now let's concentrate on the ischemic stroke. Risk factors, we all know them. They're the same risk factors that contributes to heart disease. If you have an atherosclerotic disease in the heart, it's a generalized problem, so you will have it anywhere else. If you have an ischemic limb, it's going to be everywhere. Hypertension, diabetes, smoking, high cholesterol, and AFib. Those are very common in our society back in the Middle East, unfortunately, especially the smoking. But also a few things that you have to keep in mind: cardiomyopathy, congenital heart disease. Sickle cell disease is one of the diseases that is common in our area, and it's easily treated to prevent strokes if you tackle the hemoglobin S level. And drug abuse as well is one of the risk factors. Act fast. This is what you need to deliver. Stroke is a reversible disease. It's no longer something that you come to the emergency, oh, sorry, you had a stroke, nothing to do for you. Let's try aspirin and you go home. No, it is a treatable disease, and I will prove that to you. Now, let's put statistics and neurons into perspective. I like to put things into perspective. So if you have a patient now with acute blockage in the blood vessel in the brain, let's say MCA blockage, middle cerebral artery blockage, right now, and you just fast forward 1 second, how many neurons you lose or that patient loses? It's 32,000 neurons in 1 second. And if you fast forward 1 minute, it's 1.9 million neurons that you lose without regeneration. We know the neurons in the brain, if you lose them, they do not come back. You can find bypasses, there is neuroplasticity, there is some recovery, but if you lose a neuron, they do not come back. That's why we get memory issues and dementia or cognitive issues when you live longer. If you fast forward 1 hour, 120 million neurons you lose without regeneration, and your brain will age by 3.6 years. If you have a full-blown MCA stroke, no treatment offered, you did not come to the hospital, no TPA given, no thrombectomy done, 1.2 billion you lose, and your brain will age almost 36 years. So if you're 20 now, you're going to be 56 after the stroke. Brain function. Pre-hospital care is the key in stroke. It is a key, And that's why if I would encourage you as a team in UJ sign, is to tackle the pre-hospital. Try to educate EMS. Try to educate الدفاع المدني, the ambulances. Try to educate the community. Go to schools, go to universities, do booth in malls and all these things. Teach them that not only when you hold it's a heart attack. Also, there's something we call be fast or whatever the mnemonic in Arabic is, or Turkish or any other language, and teach the community. The kids will pick up strokes in their grandkids. The adult will get it picked up in other adults. So teach the community. This is what I would advise you, and teach the EMS one specific time. The time of onset is different than the last known well. Time of onset is when the patient discovered or someone discovered that the patient had a stroke. What matters in the treatment of a stroke is the last known well, the last time the patient was known well, which is the last time the patient was witnessed moving in a normal manner. And that's the key when it comes to treatment options. Before 1996, there was no treatment. The treatment was limited. They come to the emergency. We used to try heparin, aspirin, physical therapy. We don't know what the outcome would look like, and no treatment really. In 1996, we have the NINDS TPA stroke group study that FDA approved the TPA, which is tissue plasminogen activator for acute stroke treatment. And it was first approved for 3 hours of last known well, again, not time of onset, last known well. And then the time window was extended to 4.5 hours. I'm not going to go through the details of the study, but it shows less death and good outcome in general. Sorry, there's some delay so let's start our evolution of stroke treatment by doing a case. Let's imagine the case in 1996 and go with it throughout the evolution of the treatment. So let's say we're now in 1996, and this patient came. He's an old man in his 70s, hypertension, hyperlipidemia, coronary artery disease. He became acutely confused with right facial droop, right-sided weakness while driving his car. He had a mild motor vehicle accident, arrived to the ED an hour after the symptoms. So the beauty about this case is for a fact that the patient was normal. You cannot operate a vehicle if you're not completely normal, right? You're not going to be neglecting a right-sided weakness and driving a car. It's impossible, or almost impossible. So that will give you a clue that the time of onset here, which is the time of accident, is the last known well, most likely. So when he came to the emergency, aphasic, profound neglect, does not recognize deficits, left gaze deviation, and so forth. So here in the US, we have a system of care. So EMS will notify the hospital that we have a patient who has a BFAST positive, or a race positive, or a Cincinnati scale, which is a scale that's used by EMS, Emergency Medical Services, which is the Difa' al-Madani in Arabic. And they pre-notify the hospital. They go to the nearest hospital and they say, we have a patient with expected stroke. So the team will be waiting for the patient in the emergency, and we jump on the patient immediately. We ask about the last known well, what's the patient history, any contraindication for TPA, and so forth. So the next is you get the vitals. This is the vitals, nothing really striking. And we collect the NIHSS scoring system, which is a standardized test to detect the severity of the stroke. NIHSS, I can give you a whole lecture about it. There's some advantages, disadvantages. There are some pitfalls in NIHSS. There's some limitation, but it's, generally speaking, it's like a Glasgow scale. So Glasgow scale, if I call someone and say Glasgow scale is 3T, people will know that the patient has no movement and a tube in, right? So the same thing. Here, anything above 6, we believe anything above 6 in NIH is a severe stroke. In this case, the patient has all these points positive, and the NIH is 26, which is a very severe stroke. So what's next? We do a CT scan. So if someone asks you a quiz test, what are the 2 tests you need to determine the eligibility of a patient for a TPA in acute ischemic stroke? Is 2 tests. Number 1 is CT scan of the head to rule out hemorrhage, because if there's a hemorrhage, then that's it. You stop, you do not give any TNK or TPA. And the second test is blood glucose test. And those are very easily done in the emergency. So this CT scan, there is no bleeding. What you see here, which we'll talk about later on, is a dense vessel that reflect that there's a fresh clot in the MCA right there. What are our therapeutic options now in 1996? If TPA is approved, so TPA is the test. So we ruled out contraindication and we give TPA. And the patient did not improve. So the scientists paused for many, many years and they said, is that it? And definitely there's some limitation of the TPA. Only a third of the patient comes within the time window. Only 10% of the patients are eligible for TPA because of the contraindication, the time window. And we know that 20% of the patients will come up to the emergency after wake-up stroke. So the time of last known well was probably last night. So we do not know, did the stroke happen an hour before they were awake, 2 hours, 3 hours, or really when they went to sleep immediately. And we know time that the TPA is not a strong medication to lyse the clot if the clot is big. So the scientists, again, looking at those limitations, they start questioning, is that the only therapeutic option? And they looked at the cardiologists. The cardiologists, they all the time go and try to open the coronary arteries to save the heart. Now, the difference is cardiologists, they have an easy life when it comes to detecting acute myocardial infarction or STEMI, ST elevation MI, myocardial infarction, because they just need 2 or 3 things. They need the typical chest pain, ST elevation on on EKG or ECG, and a troponin or cardiac markers. This is not easy for neurology. You cannot. There is no blood test. There is no brainwave test that you can do to detect stroke. So the level of complexity receiving the patient is different. But do we have a stroke that looks like a heart attack, which means easy to identify, bad outcome if you do not go aggressive and open a blood vessel, and can we retrieve the clot? Is the clot physically can be removed? And yes, looking at those strokes from 1996, with time, we did know that the bigger the clot, the more mortality, and the less likely the TPA will work. So for example, if you have an ICA occlusion in one of the sides, which ICA means internal carotid artery, 53% of the patient will die, even with the best treatment at that time, especially if you do not recanalize the blood vessel. MCA, 30% will die. Basilar artery, up to 90% will die if you do not open it. And this is the statistics of how frequent is this. 40% of the large vessel occlusion, the clot that block the blood vessels, comes in the MCA, 26% in the ICA, and 8% in the basilar. And do we have a way to measure the outcome? Like in terms of the heart, you measure the outcome by cardiac output and ejection fraction, losing the heart function. Do we have a way to up the outcome after a stroke? Yes, we have something we called modified Rankin score, which is a score that we use to evaluate the functional status of a patient after a stroke. It starts from 0, which is us as a normal person, and 6 is death. And those are 1 to 5 that you see here on the slide. 1 is you have a stroke and you recover completely, and you are now driving, working, no problem. 2, you can walk without assistance, probably maybe some numbness, maybe some facial droop, but you can function, you can walk, and you can probably go to work. 3 is using a cane or a walker. 4 is using a wheelchair only. And 5 is vegetative state, which is on the bed with a feeding tube, and you need 24 hours assistant. So which one of those numbers we consider a good outcome? Is anything 2 and below, we consider a good outcome. So we have a stroke that we can pick up, and we have an outcome that we can measure. And this is just a table to show you the description of each one of those modified Rankin score. Do we have a way to go up? Yes. If the cardiologist can go to the brain, to the heart, we can go to the brain. And this is the NG suite that I use. It's a biplane, and this is the route we go to pull the clot from the brain. Nowadays, we use also radial access as well. So that made scientists or neurologists, neurosurgeon, radiologists excited. So they started trials in 2012. And unfortunately, they were very excited to the extent that they used all generation devices. They used a device we called Mercy device. This is how it looks like. It looks like a coil. It was designed, it's still used, it's still in the market, but it's designed to retrieve foreign body. Like, for example, you're doing embolization of a spleen for any disease, and you have a retained object in the blood vessel of splenic artery or vein. You retrieve it by going with this coil. You just spin it, the foreign body gets caught on it, and you just pull it. So they went to the FDA and they said, listen, we pull foreign body with this coil kind of device. Foreign body, a clot in the MCA is a foreign body. Can we use it to do that? And they give them the clearance. And that was one of the pitfalls that they were in doing that. All of those studies in 2012 they were stopped due to bad outcome, and the treatment was not approved. They were taking all patients without even imaging. Anyone comes into the door with a stroke, they go to the cath lab and they try to remove the clot. So the mortality was higher, the morbidity was higher, and they were all stopped. But again, physicians do not give up. They designed devices that are meant for clots. This is one of the famous devices that we use. We call it stent retrieval, which is a stent that you deploy and it incorporates the clot, and then you pull it with the clot after 2 to 3 minutes. And they designed multiple devices, aspiration device, stent retrieval in different companies, and so forth. And they did randomize the patients in a very scientific way and very precise way, that they pick up the patients with large vessel occlusion, LVO only. And there were 5 randomized trials. The only trial that was completed to the end is the first one, MR clean, but the rest were stopped prematurely, not because there was some high mortality, because the first trial showed efficacy. They said, okay, this is very powerful, stop all the trials, go ahead, it's approved. And this is just a table. I can share the slides with you guys if you want, but this is just a table of showing you that the only trial that was not stopped is the first one, but the one they were all stopped prematurely because it was showing efficacy. What we learned from those studies is use the proper device. Second, pick up the right patient, which means not every stroke patient comes in, you take them to the cath lab. You have to prove that they have a large vessel occlusion by doing a CT angiogram. So now the protocol says, let's go to our case. So the patient did not improve. We shipped them to CT angiogram. And this is the CT angiogram showing the left MCA being blocked. So now we have a stroke that did not improve to TPA, not that we wait for TPA to improve or not improve, but we have a stroke that we picked up MCA occlusion on a CTA, and the patient has a bad stroke. This is the left MCA occlusion. And this is what was done to this patient. So this is the patient was shipped to the angiogram immediately. And I'm just going to show you the technique, one of the techniques that we use. Excuse me. So this is what we do. So we go through either radial or groin, common femoral artery, and we go all the way up to the brain with the small wires and catheters. So this is the clot in the MCA. So we traverse the clot with a small wire, introduce the stent slowly over the microcatheter. We deploy the stent. The stent does not stay there. It's held in a stick in a wire. We wait, and then we pull the clot with the stent. And this patient, instead of being dead in 40% of the time, this patient walked out from the hospital walking with no deficits. And this is how the clot looks like. This is one of the techniques that we use. So this patient went home. Instead of being dead or in a vegetative state, needing a tracheostomy and a PEG tube, he went home with no deficits. Now, Those studies that we showed here, sorry, I'm just going to go back, only approved the mechanical thrombectomy for patients from 0 to 6 hours. That was the maximum benefit that they saw. Not that they did not see benefit after 6 hours, but that was the approval from FDA. 0 to 6 hours. That's it. After 6 hours, we tend not to do anything. But again, scientists are very stubborn as usual. So they said, what about 6 hours and above? What about 6 hours to 24 hours? Because they were doing some cases afterwards and it showed some outcome. And even those trials, if you look at the sub analysis, patients above 6 hours also did show some benefit if they underwent thrombectomy. So we have two famous trials called Dawn and Diffuse, and those were done in 2018. And those looked at the patients beyond 6 hours. And the concept behind those trials was this. So we know that if you have a clot traveling in the left MCA, in the left ICA, like this one here, and it gets stuck in the MCA, we do not know from studies and neuroanatomy, neurophysiology, that we know for a fact, sorry, that when you block the MCA, not the whole MCA territory will stroke out immediately. But that's incorrect because we have what we call it ACA to MCA collaterals, and we have leptomeningeal collaterals. So there's the collaterals. So there's an area that's still supplied, but if you do not save that area, it will stroke out with time. So the concept of a core and a penumbra came from this. So when you have an MCA blockage, you have a core in the middle, which is a small area of non-reversible brain tissue, and a big penumbra area around it, which is the penumbra is the area of the brain that is struggling, thirsty for blood, and it's screaming at us. If you give me blood, I will come back and function, just restore the blood supply. And this is the concept of the late stroke trial after 6 hours, is if the core is small and the penumbra is big, go ahead and do the thrombectomy. The more you wait, the more bigger the core will become, and it eventually will be the whole area of core, and there's no way you can save the brain at that time. That was the understanding at that time. Why I'm saying this? Because there's some study that came out in 2023 and 2022 that also changed our concept of a core as well. But for the time being, we have to minimize the core and increase the penumbra. Can we pick up this? Yes, if you do a perfusion scan. So now we're adding a new study. So before this, we used to do CT angiogram. Now we're going to add a CT perfusion. CT perfusion will give you that idea of how much of a core is and how much of penumbra is. And that is a separate lecture that we can go through. But this is what the concept is. If you have a small core, a big penumbra, go ahead and do it. This is the Dawn trial design. It looked at the patients up to 24 hours of last known well, and they looked at the 90 days outcome. I'm not going to go over this, but you can see that there is a shift in good outcome. This is the modified Rankin score in the control group, and this is with the thrombectomy. You can see that we increased MRS of 2 from 4 to 17%, and also those were decreased. MRS of 4, which is being on a wheelchair, decreased to 13%, and so forth. This is the safety. There's no significant increase in intracranial hemorrhage, because that is the concern. If you remove a clot from a place that's already infarcted, you might end up with a hemorrhagic transformation. That was not significant. And it made it to the guidelines. So now it's in the American Stroke Association guidelines that it is approved, and you can do thrombectomy in specific subset of patients up to 24 hours of the time of last known well. And this is just some example. So this is the ischemic core, and this is how the penumbra looks like. This is the core penumbra. The mismatch is high, and the mismatch volume is high. This is a good case for thrombectomy. Again, this is using a rapid AI, artificial intelligence application. It can pick up the difference between the core and the penumbra and gives you a more understanding of. And this is just some pictures to show you MCA blockage. This is how the clot looks like. This device that was used here was a aspiration device to aspirate the clot. Now, how effective is this treatment? It is very effective. I'm going to pause here because I want to just explain a concept for you as a physician colleagues. So we know that in statistics to evaluate efficacy of any treatment, we look at the number need to treat, which is the number of patients you need to treat with a specific medication or device or procedure to prove outcome. So if you can prove to me that you only have to use your medication once or twice to show me the effect, is better than if you come to me and say, listen, I have to treat 100 patients to show you that this medication helps. So the lower the number, the more effective the treatment is. I'm going to show you some number need to treat for a commonly treated diseases in medicine. Bariatric surgery for obesity. It's very commonly done in Jordan in specific. I did surgery residency for a few years. I know gastric sleeve, gastric bypass is very commonly used. And you can see to prevent the primary or to reach the primary outcome from all the studies that approved bariatric surgery, you need to do 75 cases to prove the outcome in one patient. Aspirin for MI, we are commonly educated that if you have someone with chest pain, let them crush aspirin. It is very effective. I'm not denying the fact, but the evidence behind it is you have to give 50 patients crushed aspirin to prove the good outcome, which is preventing heart failure and so forth before reaching the hospital. But still we do it. PCI for MI, cardiac cath and stenting, revasc of the coronaries with MI. You need to do 20 patients to prove outcome in one patient, which is preventing low EF and heart failure. Sepsis with antibiotic, lice treatment, defib for VFib, you name it. Now, when it comes to mechanical thrombectomy for large vessel occlusion, the number is only 1.5 patients. So I need to only treat 1.5 patients to prove to the public that this treatment is very effective. And yet, it is not available in all the countries. It's not available in patients who need it. And it's not even well recognized in most of the countries in the world. And this is very sad. So by all means, mechanical thrombectomy for acute stroke, large vessel occlusion, it is the most effective treatment of medicine since medicine was invented. There is nothing more effective than this. And this is if that was for 0 to 6 hours. And if you look at 6 hours and up to 24 hours, the number does not really get worse. It's 2.5. So bottom line, stroke for large vessel disease, and even with TPA, TNK is a treatable disease. You have just to go fast, and treatment can be offered for mechanical thrombectomy up to 24 hours. Now, what about patients with large core? We spoke about penumbra and large core. Again, we're trying to see what if we remove the clot from a large core patient. Is large core really what we believe is a core, or is it something that still can get revived if you remove the clot? And there's a lot of neurophysiology and histological evidence that even the core, if you restore the blood supply from a core brain, you still can get function back. And why people were looking at large core? Because 20% of patients with acute ischemic stroke with LVO in real life has a substantial ischemic region in the initial neuroimaging, which deemed them not eligible. Although sometimes if you do an MRI, that perfusion scan is not as accurate as you would expect. So we have 6 randomized trials that were all done in the last 2 years. And they looked at the patient with large core. And they took patients with a core of as big as aspect of 5, 4, 3 even. And believe it or not, even if you remove the clot from a large core patient, there is a good chance of better outcome with a statistical significance, with no increase in hemorrhagic conversion. So I think the future of mechanical thrombectomy is not only penumbra core. I think in the coming 2 years, you're going to see patients getting treated with mechanical thrombectomy, even with large core, based on imaging classification that is still in the process of trying to clarify what imaging you need to identify large core from not large core. But I think if you look at the future, I think the future is coming up very soon that we're going to be doing thrombectomy for large core stroke as well in a specific subset of patients. Now, there's a lot of talk about how to increase access to this powerful treatment. It is a very powerful, as you say, as you did see in my presentation, hopefully, and I hope that you're all convinced that this is a very important topic to spread the education everywhere. So I would stress the point that education is the key. If the patient does not reach the hospital, we cannot do anything. So yes, we need to build a system of care in the hospital, but if you build the top-notch hospital care, let's say University of Jordan, and patient does not come, you're going to be just serving nobody. So education, community education, go to schools, go to charity places, go to football stadium, put a booth and educate patients while they're coming in. Training, you have to train EMS. I think the key is EMS or Difaa al-Madani or 911 or 119 or 191, I don't know, whatever you have it in your country, which is the emergency services. Those are the key to educate. Then there's some talk about mobile stroke unit. So mobile stroke unit, we'll talk briefly about it. Again, you can give grand rounds about mobile stroke units. I'm happy to talk about it in the future if you want. But mobile stroke unit is something evolving. It is effective. There's trials that looked at it. It's effective, but we'll talk about the limitation. And what about globally? What we can do globally to increase the stroke awareness? Those pictures of the mobile stroke unit. It's a actual ambulance. Inside the ambulance, instead of having a bed and IV lines and EKG and so forth, you have an actual CT scanner inside the ambulance where you can get the patient stroke suspected, get in, have the information, last one well, get a finger stick or a glucose point of care, get the glucose, put the patient in the CT scan, do a CT, rule out hemorrhage, and then give TNK or TPA immediately. Even they went above and beyond. There is some mobile stroke unit that they have a CT angiogram capacity. That they can do a CTA and CT perfusion, and then they can route the patient to the place that they have neurointerventional capability as well. So limitations or things that you have to keep in mind when you talk about mobile stroke unit, MSU. You have to equip that mobile stroke unit with the proper personnel, radiology technician to run the CT scan. You need a nurse or a nurse practitioner to see the patient, get the vital signs, and observe the patient. And you need a neurologist, either in the ambulance, in some cases here in the US, but for the most part, they have a telemedicine. They have a camera at the base of the ambulance where they can see the patient. They can move the camera right and left, see the drift, and do the exam to get the NIH. So that is limited because of the limited practitioner across the globe. It's very difficult to maintain this. Now, second is the cost. It costs $1 million US to purchase, and the maintenance per year, it will cost 1 million as well. So that will come into reimbursement. Is it reimbursed by insurance? I'm talking about the US. If it's reimbursed, how much reimbursement? Can this reimbursement maintain this ambulance or no? That is one of the limitations that they have. Do we have studies? Yes. We have Be Proud and Best MSU. They proved that they increased the door to needle, which is door to TPA. They proved that the outcome is better. But again, the limitation is the problem, even in the US with high resources situation. Where do we stand globally? Again, if you look at global, stroke is the second leading cause of both disability and death in the world. It has, unfortunately, a high burden of disease in low and middle income countries, which is really sad to know. Low income country, they cannot afford the treatment. Those devices are very expensive, but also the burden of a disease is more high in the low and middle income country. That's why I think what you're doing, guys, in your institution is great, and I would encourage you more and more to keep on going and increase the education. In 2016 only, there's 13 million new incidents stroke globally. and 10 to 20% of those were LVO, and only 100,000 mechanical thrombectomy were done globally in 2016, which is very, very sad when it comes to how effective this treatment is. This is just one paper I looked at, which is interesting to see. Do we have published data? The data that I gave you in 2016 based on surveys. There's no really data. Look at the area where you guys are located, Jordan, Middle East. I have worked with our beloved people in Turkey. They are really building a great system of care there, but they are facing some limitation. Most likely, or most commonly, is the financial support. But look, there's a lack of studies across the globe, and you imagine with those data that I presented, and this kind of unpublished data, how much is the global impact of a stroke if you look really at real-time data. Before I finish, I would encourage you guys to get involved in Mission Thrombectomy. Mission Thrombectomy is a global non-for-profit move under the SVIN. I'm not trying to promote anything, but I think what you're doing is lined up with the mission of Mission Thrombectomy, which is increasing awareness. I run the executive committee board in the Middle East area. I can tell you that the only 3 countries that we have, or 4, I would say, that we have communication with is Qatar, Egypt, and Iraq, and Saudi Arabia. Unfortunately, the rest of the countries, we have difficulty communicating with them to help them change the policy in their countries to make mechanical thrombectomy as approved by the government for all people. We want to get access for this powerful treatment to everyone in the globe. As I told you, Saudi Arabia is on the path. Turkey is on the path. Egypt has been doing a great job. Iraq is starting. Jordan, we have 0 connection. We tried multiple times, and I'm happy to talk offline so we can really help out. Palestine, again, there is no, it's very difficult resources wise and everything. But I'm happy to answer any question. Happy to work with you as much as you think my presence is needed. And thank you for the invite again. Thank you very much.
Thank you, Dr. Mohammed. First, thank you for the, of course, awesome webinar. And secondly, thank you for the kind words promoting and praising our work. We really don't do this for praise, although we do love your praise, but we don't do it for praise. We actually do it to change things. So exactly the way that UG Science started, we didn't find a support system for the students. This is the way we run our operations. We want to be the change that we want to see, basically. And alhamdulillah, the team does embody that message. It's really interesting to see how stroke care is evolving globally. And just before we start the Q&A, please, everyone who has a question, just type it in. I just want to kind of draw a parallel. So, of course, Dr. Mohammed talked a lot about how stroke care is evolving. Just the last comment, how there isn't any stroke care in certain countries. Let's take an example of neurosurgery. So 30 countries currently around the globe, mostly low-income countries, don't have neurosurgery care. They don't have a neurosurgeon in the entire country. And so you can kind of draw a parallel where that's an easy solution. You just either, kind of take in trained neurosurgeons, just place them in the country, and then that would technically be covered. And all the medical infrastructure, like, the tools, the surgical equipment, blah, 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 they can follow, or you train one. Imagine trying to introduce a whole and comprehensive stroke care unit. Just one across the country. So I've actually attended the SVIN conference a couple of weeks ago. It's just phenomenal. It's way too complex. It's way too expensive, but they're doing it. they're doing it. So that's what SVIN and in specific mission thrombectomy is about. And it's okay, doctor, and you can promote it. It's fine. Don't be shy about it. I'll read out some of the questions now. I'll leave my own question last. So we have Sadil Bani Khalid. She's asking. She has actually multiple questions. You can unmute, doctor, if you want. Does the fact that ischemic...
Go ahead. Go ahead.
Okay. Does the fact that ischemic stroke is more prevalent than hemorrhagic have any clinical implication? Like, don't they always do like MRIs regardless?
So I think it's a blessing that ischemic stroke is higher than hemorrhagic, because hemorrhagic, you do not do anything other than relaxing the brain with hemicrania and so forth. I think we have so much on our shoulder, given the fact that 85% of the stroke is ischemic. So we have to really try to modify the risk factors and really go aggressive with the treatment options we have to reverse the stroke and improve the outcome. That's the clinical implication that I see. Is this is a more burden on us, that we have to really push hard to get those patients, first of all, a primary prevention, secondary prevention for stroke, like risk factors that we do really poor, not us as a physician, it's just the community. They do not believe, some people, they believe in herbal and stuff like that. And also on getting the treatment, effective treatment to the patients needed as soon as possible.
Okay. So it does have clinical implications. Based on treatment, the treatment modalities. I'll because Sadil has asked so many questions, mashallah, very invested. I'll just switch over to another person. So, okay, if TPA does not work, I guess in certain situations it doesn't work. Is that always an indicator that the stroke origin is outside of the brain, i.e., an embolus, or?
No, not necessarily. So, I will answer this question in two ways. So TPA does not, so the outcome of the TPA is not always immediate. I want you to remember this. The outcome is at 90 days. So all these trials that looked at the TPA, or let's say thrombolytics, because now TNK is approved as well, or not approved, is on one of the options, is 90 days. So you do not expect giving the medicine and waiting for the patient to improve. That's why if the patient has a large vessel occlusion, we know from the get-go, patient has a lot, and the patient is also eligible for TNK or thrombolytics. We give thrombolytics and we send the patient to the cath lab. We do not wait in the ED 1 hour, 2 hours to see if the patient improved. That's not happening because the outcome is not immediate. You see, I think 5 to 7% of the patient, you see the outcome immediate, but most of the time you do not see it. You see it long term. So I would refrain from waiting. If the patients take it separate, TPA yes, no, LVO yes, no, they do not interact. If you give this, it doesn't mean that the patient is not eligible for this, and vice versa.
And mechanical thrombectomy is also limited to large vessel occlusion, right?
Correct. So now definition of large vessel occlusion is evolving. We used to say large vessel occlusion is MCA, A1 ACA, maybe ICA. Now we go to M2s, M3s. So there's a lot of talk about, even we call it, instead of large, we call it medium size. We call it MEVO now, ELVO, MEVO. That's a term that you will hear here and there as well.
I guess that's as the equipment gets smaller.
Correct.
Okay, so staying on the topic of TPA, kind of, or on medical pharmacotherapy. So regarding a patient pre-hospital, he's already been diagnosed with stroke. Is it okay, or do you think it's recommended to give aspirin when suspecting stroke immediately?
That is something that we cannot do, not like ischemic heart disease, because what if the patient has a hemorrhagic stroke? You crush aspirin, then you inhibit the platelets, then you go into a worse situation. No, the only thing is, that's why it's very, very difficult for us to know which is which, other than mobile stroke unit in the field. So that's why I say just come to the emergency. That also a follow-up point that might come up from any of our colleagues on the call is blood pressure. Should I control the blood pressure? Should I keep it high? No, we just keep it as is. Up to 200, I think you can keep the patient systolic until they reach the hospital, because you never know, is it hemorrhagic, ischemic?
Yeah.
So that's also difficult to determine.
Yeah, that's just to keep the brain perfusion going in case it's ischemic, and of course you want to lower the blood pressure if it's hemorrhagic.
Yes.
Okay. Okay, last two questions, I guess. Since time is a critical factor, patient shows symptoms of stroke in the hospital and significant NIHSS score, but CT scan is inconclusive. Proceed with TPA or wait until you confirm radiologically.
Can you just it just cut off 1 second? Can you repeat the question, Ali?
Yes. So in hospital patient, inpatient, NIHSS score is indicative of stroke, but the CT scan is inconclusive. Do I go ahead with TPA or do I wait for radiological confirmation?
Yeah, so again, it's a system of care. You need to confirm there's no hemorrhage on CT scan. Inconclusive is not something that I will take it lightly. So here in the US, what we do is either a stroke neurologist will look at the CT scan and just determine, but we always have a radiologist. They have to respond. We have always goal and time limits. So from CT scan done, like in my place, to a formal radiology read should not be more than 7 minutes. So you have to set goals. I'm not saying that for you to be like, maybe you can start by 10 minutes, 15 minutes, because, again, time is brain, but you have to have a team, all of them on the same page. Inconclusive, I would be very, very cautious, especially if it's inconclusive for bleeding or tumor or any of the contraindication.
Yes, okay, thank you. Last question, this one is mine. Throughout the end of the webinar, you talked about probably going more towards doing mechanical thrombectomy for large core strokes. My question is not directly medical. I like to think more of the administrative or like in organizational things. So our stroke units right now built to handle the stroke, well, basically large core stroke patient volume. If you decide, because basically you lower the threshold of people who have to do mechanical thrombectomies. So do we see you just doing mechanical thrombectomies all day in like 10 years?
That's exactly one of the criticism of these trials in the US. Again, despite having all resources you can imagine in the US, that is one of the big problems that we will face. In my take home, it's true that large core patients, they did well, right? But they did well relatively, not as well as the good ones in the Dawn diffuse and the MR clean. So my take home, if I'm gonna really think about this in a very scientific way, I would say the large core trials gave us more information that we need to have conversation with the family before pursuing the treatment. For example, if the patient comes in and you know that it's a large core, you will save the patient, but you probably improve the outcome from 5 to 4, like from being maybe let's say from 6 to 5, from being dead to a 5, which is vegetative state. I'll probably have a conversation with the family. Say, listen, we can do it. I don't know how he's going to end up, but there's a high likelihood that he or she will be in a vegetative state or in a wheelchair. And then leave the family decide. If they have advanced directive saying, no, leave me alone, I want to be walking, running every day 5 miles, then you do not need to do it. But that's a big question. And also you have to have a buy-in from neurosurgeon, because if you do it on large core and you end up with the edema after the core is infarcted, you need someone to help you to do a hemicrania. It defeats the purpose to do a MCA thrombectomy, end up with an MCA edema, then the neurosurgeon comes back and say, sorry, I'm not going to do hemicrania. So why did we do it to begin with? I mean, so I think it just, I don't think we should jump onto a large core immediately. I think it should be more conversation team, like neurosurgeon, neurologist, intensivist, and then the patient's family themselves, what their expectation.
Yes. Okay. So just not take too long of your time. Thank you very much, Doctor. I will talk now about the partners and the raffle. If you wish to stay here and watch it, of course we will.
Unfortunately, I have to go start the case. But one more point, Ali, you pointed out is it is true difficult to build a system of care. But if you have people like you guys all together under one mission, which is serving the family, serving your beloved family, you can do it. I would say it is a lot of work to do. I would, if I would advise you, is try in pieces. Maybe the easiest way probably is to educate the nursing staff, your colleague, which you're doing now, and then maybe educating the community. Then the emergency medical services and getting it approved and buy-in by the government, because to build up this a huge project, you cannot go build it up in a private hospital where sad to say this, if you have the money you get treatment, if you have no money you do not get treated. It has to start in a big governmental base, and that's how machine thrombectomy will help you. We have a white paper that we wrote in multiple languages. We can give you our ambassador, go with you to the healthcare administration in your country. We can fly in and do it, talk to them, show them the white paper, show them how effective it is, how it's gonna save the society. If you do not get it approved by the government to cover wide bases of patient, it's gonna be difficult. Then you start playing like Lego. Which hospital should be the main hub that we will have TPA and thrombectomy? Which places will have only TPA and will ship the patient? But I think start small pieces, or go to the media, educate community, educate your nurses, let them be very, very familiar in the ED, in the ICU, and then government is the key.
Yes, we totally agree, Doctor. And
thank you very much again.
You're no stranger to our government, but yeah. But yeah, I think no, I would love, or UG Sign would love to do that, because this is what you're looking for. This is exactly what you're looking at. And even if we can have just a tiny little bit of impact before we finally go off to residency, and even throughout, I think, yeah, we would definitely take on that chance. And thank you for extending this. Inshallah, I can tell you all about our struggles with the university and the government later.
Yeah. Thank you very much. Thanks everyone on the call, and good luck. If you need me, please reach out to Ali, and he can share my information with you if you need any help anywhere in your career or building a stroke team.
Sure.
Thank you very much. Good luck with the raffle. Okay.
Yes.
Well.
So please don't leave yet. We still have a raffle going on, just to talk about our partners, and of course announcing the winners. Let me just share my screen right here. Entire screen. Okay. Yeah. So. Okay. So just to answer, I think no, there was one right question that I still wanted to see. I'm sorry for everyone. I couldn't ask every single question. Because as you saw, the doctor actually had surgery. So, okay. Hazar al-Abid, yes. That's a very nice question. How can one join UG Sign? Thank you for asking that. So UG Sign is based in the University of Jordan Medical School, Jordan University Hospital. We're a local chapter. So right off the bat, if you're a medical student in University of Jordan, you can join. You're eligible. If you're not, I'm sorry to say, but we have to maintain the scope of our practice. If you're within any other Jordanian university, I think you can join. There are now signed chapters in Balqa, Yarmouk, and Hashemite University, and just Techno. They also have signed chapters, and I've already talked to Yarmouk and Balqa and Techno presidents. They're all great. They all do great work, mashallah. You'd be in good hands. In case you're in University of Jordan, just DM us and we'll tell you how to join. So just to talk about our first partner, both partners, of course, they promoted or do promote our activities. We don't have much financial capacity, but that's what their partners are for. So Socrates Academy is a medical education website based in Jordan, and they specialize in tailoring their courses towards the medical schools in Jordan, right? So you are a medical student in Balqa, your internal medicine course on Socrates Academy would be different ever so slightly than an internal medicine course in a different university in Jordan. And they bring you people, smart people from your own university, people that you might know, to present that. So it's not even like they give you the knowledge just in general, the medical knowledge. No, they tailor it to your curriculum, right? Which is primarily what you want, right? You want to get good grades. And so this is their website, mashallah. It's great. They also have their contacts. These are just some of the courses that they offer. They do run discounts and offers from time to time, so keep an eye out. They also have, of course, their Instagram right here, and give them a follow, keep up with them. And just to read out the 3 people who just won. So Ibrahim Abu Hadba, congratulations. Hindu Hedi and Noor Al-Afishat. So these are our 3 winners. Congratulations. We will contact you per email, the one that you left in the form, and we will help you claim your prize. Thank you, and thank Socrates Academy, of course. Coming to the second prize. So Crosstalk Lab is a research foundation based in Qatar. They're also registered in the USA. And their founder, Dr. Anouf Mahmoud, she's a PharmD, and Crosstalk Lab is really a research foundation where they're all encompassing, they're comprehensive. They can help you in research in medical sciences, any other health science, social science, engineering, everything. They cover everything. This is their website. I like to describe Crosstalk Lab as, if you have any question within research, that's the person to ask, or that's a go-to company / foundation, right? And since it's mostly medical students here, I think these are some of the services that they offer, and I think you will specifically enjoy the mentoring service. So let's say you or a small group of you and your friends, you don't have your hands on a research project yet. They can mentor you on how to get it started, and how to find your research idea, right? How to start and structure the methodology, how to analyze the data, blah, 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 right? Let's say you already have one, and you want to just ask a specific question, you're facing a specific problem, maybe in the data analysis, maybe in interpreting the results, maybe just how to write or how to choose a journal. So this is where the consultations come in, right there at the bottom. They also, let's say you have written everything and you're just planning on submitting it to a journal to publish. This is their third service, is scientific writing, right? They can comprehensively and holistically review your entire paper before you submit it, and just help you out, tell you, change this thing, change that thing, and as I said, it's comprehensive. I know most of you probably won't pursue postgrad roles, but they actually do offer kind of a helping program. They can teach you and help you on securing scholarships, how to apply to them, finding them, okay, applying to PhD programs, starting your thesis, all of that, applying to awards, all of this. And of course, something I don't think many people will need, but just to highlight how comprehensive Crosstalk Lab is, science to business. So let's say you have a research idea, you have a patent, or whatever, and you want to patent it, or you see commercial potential. So they can help you out in this even, right? So you do research, you find something, maybe a health tech or a medical device or whatever, you want to start making money off of it and, benefiting the people. They can help you out with that. Also run workshops, right? So basics of scientific writing, primarily to, or not primarily, but this might be very useful for people in their basic years still. Novel idea to business, piggybacking off of the science to business service. I actually did the hands-on Python healthcare course just recently. It's amazing. Research proposal writing, they do all of this, right? So from now on, any research question you have, just go ahead and visit their website, right? And keep an eye out on their social media, because they do run monthly webinars, monthly courses. I hope you all enjoy this. And to announce the winner is okay. The winner is Bana Al-Najjar. So congratulations, Bana. We will get in contact with you to help claim a prize. Other than this, thank you everyone for joining today. We hope you learned something, and give us a follow on UG Sign. Hopefully we can see you in different webinars. Thank you all.